This is the DocNation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers.
Hey, Matt, thanks for joining us. We appreciate it.
Thank you.
And we appreciate it for a couple of reasons. But number one, can you explain what your last 24 hours was like? As we were talking off camera there, it wasn't a typical last 24 hours for a human being.
Mm-hmm. No, exactly. First of all, I would like to go ahead and make an announcement here that anything I say here, all of the opinions and anything I say here are just expressly my own opinions. Don't reflect the Yale School of Medicine or Yale New Haven Health. So that kind of gets me off the hook a little bit. Yeah. Anyway, last 24 hours. No, I show up at 6:30, 7 o'clock in the morning, typically do a full load of cases throughout the day and then any add-ons throughout the evening, and then stay in the hospital for any intubations, other procedures, any emergency cases that, arise throughout the evening. So I've been doing this for 25 years. And have done in-house call for a majority of that, anywhere from one night a month to I'm currently doing about 3 nights per month, which is the average here. So,
and you slept at the hospital last night.
You get lucky.
That's a good night on a very comfortable bed.
No, it is. That's a good night. But I will tell you, as I'm getting older. Yeah, I'm in my mid 50s now, and this whole concept of staying overnight in the hospital it's getting a lot tougher. It's one thing when you're in your 20s and 30s and you have a lot of energy. It becomes a recovery mode if you haven't gotten much sleep. But I think this is kind of a good segue into what we were discussing prior to this. Is I think the number one problem right now facing healthcare, especially with regards to physicians, is continued burnout. I know that, COVID really exacerbated the rates and prevalence of burnout. A lot of physicians, I think somewhere on the order of 100,000 physicians retired or left practice in the last 3 to 4 years.
100,000?
Nearly 100,000 physicians, yes.
Which is what percentage of the total would you estimate?
Well, the total workforce is a little over 1 million.
So in 10 years, if that continues to happen.
Right. It's going to get worse. Right. So I think, burnout leads to lower quality outcomes. It leads to more absenteeism, productivity issues. I mean, it's just a whole laundry list of consequences of burnout. We really do know what the causes are, but systems have a difficult time trying to address them. And that's because now, 80% of doctors are employed. So what have we lost? I mean, I was originally in private practice in Tucson for 12 years. And I did have agency and autonomy. And also when I was the medical chair of anesthesia and the chief of staff down in Tucson, when you are independent and you are part of a private group that's contracted in a hospital, the voice at the table is a little bit louder. And I believe, in my opinion, people pay a lot more attention to it. Now that physicians are employed, I think in some systems, some physicians may see some things or have some issues, but they're a little bit more wary about bringing those issues up to the front because of you don't want to bite the hands that's now feeding you, if you will. So
how much different has it then shifted for you from having the autonomy back then to now? And just in general,
I've had 4 different employment arrangements in the last 4 years. So I went from, leaving my practice to joining a large national, group. Mm-hmm. And then we lost the contract in the middle of COVID. Then I became an employee of a large regional health system, had tried to renegotiate or negotiate some of my leadership responsibilities and compensation time to actually do those duties. Wasn't really particularly happy. So what's happened to me is Yale basically cold called me and recruited me out of the blue. And this is one thing that I don't recommend people do, but I did it anyway. I had a Zoom interview over an hour and a half one Tuesday evening. An hour and a half later, I got a phone call. We'd like you to come to Yale. And I said, yes, send the contract. It was the fastest interview to contract, 72 hours, wow. Sight unseen. Yeah, it was just one of those I kind of pulled the trigger, and the only reason I did so is because my interview was superb. There were 4 physicians. I'm at St. Raphael's campus, which was excellent, and I can tell when someone's not telling the whole truth, and I could tell that they were actually telling the truth, and the stories were consistent. So it's back to academia. So
wow. So this burnout issue, what would you say if there were some specific things that could happen, some changes that could be made? What do you think are those big drivers that could lead to the environment much better for doctors?
well, I think there are 2 things that could happen across the board. First of all of the boards of directors for health systems and hospitals should have at least 4 to 5 physician representatives. And I believe that the burnout metric should be discussed on an annual basis and real efforts made to try to improve some of the systems and processes. For example, I think that, emergency room physicians, anesthesiologists, and ICU doctors and hospitalists in particular, we're experts on operations management. We see the patient workflow through a hospital. And I think that there are a lot of initiatives sometimes that end up falling flat because there's not enough input by the physicians. So I think that would, again, restore some of, not the autonomy necessarily, but I think that what we really can do is restore some more agency. In other words, give physicians a voice back into the system that we once enjoyed. But I think that there is a resistance to do so because physicians, first of all, were smart. And sometimes, we don't exactly want to necessarily toe the line, if you will, if we see an initiative that would work. And especially with the economics of many healthcare systems being impacted by lower reimbursement rates across the board, any initiative that would not increase revenue or would slightly, impact revenue in a negative way, even if it was good for the physicians, it's not good for the financial health of the system. So that leads to what I call moral injury. And that's the other, aspect of all of this. The other coin, if you will, from the agency autonomy is, are the decisions being made in the best interest of our patients? And are these decisions really being made in the best interest of creating robust healthcare systems that are supportive of the physician? So it's out there and it can be done, but it takes a lot of work.
So in a way, you're saying that the leadership should be listening to the doctors on the team, and they should be giving the recommendations to leadership, and leadership should be figuring out how to take those recommendations and put them into action.
Yes, I totally agree. And that's one of the advantages of being back in academia, having physician representation across the board and across the organization. It's already baked into the system, if you will.
Okay.
So in, a system like Yale here, I think, we do have that exceptional leadership and people do listen, and the initiatives are a little easier to actually implement. And I think a lot of the academic centers as a result, and the community systems and some of the larger national healthcare systems that have a huge footprint across the US, it's much, much more difficult to get some of those initiatives across. So
Anthony, you were going to say something.
Well, I think one of the big things is not just the leadership listening to physicians, but the leadership being physicians. I think that matters the most. We really lost representation in most C-suites and most leadership. I mean, we had another doc on a few weeks ago that spoke about that, how at his hospital there are 0 physicians that are in leadership at the whole hospital. And it just doesn't make sense. I think, Reid, you went into it.
Yeah, I bang on this drum all the time, and it's 95% of administration is made up of business people like Justin and I. And when I played baseball for a very long time. I never played for a coach who didn't play themselves. And it just seems asinine to me that, in the most important sector of our economy, we have people who've never played the game running the game. And this is where it's gotten us.
Well, it has, but there's a real reason for that too. And, it's a numbers game. So, a lot of the boards of directors, for example, in many hospitals, if you look at the composition, at least half of the members of the board of directors either own small businesses or are, parts of larger corporations and have, higher level executive type positions. So You know, when I was on the board of directors, for example, down in Tucson at St. Mary's, I was an ex officio member as the chief of staff. And I learned a lot. But conversely, what was nice is being an ex officio member on the BOD, I got to participate in a strategic plan along with a couple of other physicians who were sitting on a board. So our perspective was very, very valuable. And I think having that as a balanced perspective on, you know, what may look good on paper without physician input will absolutely flat fail because the initiatives just don't align with either the doctor's workflow, their moral compass, if you will, or a host of variety of issues. Plus, there's a huge message when you don't have physicians in the C-suite. Physicians don't matter, nor does your voice matter. So it's also a symbolic carving out, if you will, and leaving us kind of left in the dark. So it almost becomes what I call the Wizard of Oz effect when you're going down the hall at the end and there's the, you know, gentleman behind the drape kind of yelling at everybody, and that just doesn't help morale at all. So and chief medical officers, of course, are getting caught in the crossfire.
That's right.
Now, I was originally wanting to pursue a chief medical officer job. I decided not to because no, I decided not to. In the middle of COVID, I found out what it was all about. You have to try to balance physician interest, and you have to try to represent what the hospital wants. And at the end of the day, whoever is writing your check for your pay and compensation you have to kind of bend to whatever they want. And the bottom line is you're going to end up making decisions that are going to absolutely irritate and make some physicians quite unhappy. So that's not a fun place to be. So your shelf life's 3 to 5 years, and you've burned enough bridges. You have to leave town and start and set up shop somewhere else. And I'm sorry, that just doesn't sound like a good time to me. I didn't sign up for that.
It shouldn't be that way. The reason that happens is because I think anyone that takes on a CMO role wants to help the physicians. That's why they started that role. But like you said, the people that sign your check are not the physicians. Correct. So you end up having to talk out of both sides of your mouth, unfortunately, and you end up breaking promises to the physicians because you have to bend the knee to the corporation. Correct. And believe me, it's not. I've talked to many CMOs. I've looked at wanting to go that route as well. It is a thankless job, and you have no friends at the end of it on both sides. Yeah. Because you're not towing the party line for the corporation, and you've pissed off all the physicians at the same time. But the reason for that is there isn't an alignment of the corporation and the physicians. That is the key problem here. And that person gets put in the middle of these tectonic plates going the opposite direction. That's why that person gets pulled apart. Right. And we have to fix the key problem of the interest of the corporation should be the same as the interest of the physician, which in the end will help the interest of the patient. And that's where we're missing it.
Well, that's it. I think that the mismatch really is the partnership is gone. Now, when we were independent and when we were contracted to hospitals and got privileges, you know, hospitals used to court business from physicians.
Yep.
Okay, because there was competition for resource, especially, you know, you're a surgeon, I'm an anesthesiologist. Both you and I are keenly aware, you know, if you take your spine surgeries, or if you take your total joint arthroplasties, for example, to the shop across town, well, you're going to lose that business. So unfortunately, the old adage one of my partners used to say is, hey, Matt, throughout your leadership journey, remember, money's the answer. What's the question? Be curious, but always keep that in mind, that a lot of decisions are going to be made around a table based purely on finances. So you have to kind of keep that in mind. Now, are those finances being used for a whole self-interest and someone's self-serving, or is this for the greater community good? So it is a blanket statement, but that's just it. And I think that the chief medical officer role has evolved. I used to be a physician who was longstanding in the community, earned respect for their peers, had already been chair, and then they kind of sailed off into the sunset and they were respected. But now you get most chief medical officers, for example, if I was to apply for one of the jobs in a large national outfit, I'd end up moving to Colorado, California, or wherever. So you dropped in, you're a stranger, everyone's staring at you, wondering if you can be trusted or not.
Yep.
And it's a whole different ball game across the board. So, I've been staying clinical. I've been full-time clinical. I've been one FTE my entire career, and I've still managed to pull off some things, which I don't know if it's from energy or what.
So to kind of go back to burnout, do you think there's less physicians or less people, less intelligent college kids going into medicine because of what they're seeing in the ecosystem of medicine right now?
No, I do think that the motive for going to medical school for some of the students is changing as opposed to when I did 27 years ago. There's new data to suggest that some medical students have no intent to practice. They're going to get their MD, and they're either going to use their engineering background or business background to either join startups or other companies as consultants. So I think some of these students, they're entrepreneurs. I mean, as much as other generations want to pick on the younger generation, they still have brains and they see the environment. And unfortunately, I think too, what's happening is some students are going into their clerkships and they're witnessing what the attending physicians are going through, and they're point blank saying, I do not want to be a part of this. And so I'm not necessarily saying that's true in academia so much, but in some of these programs that are out in the community, I think the impact there is very, very real. So, and again, it's very competitive though. I mean, I'm doing some advising for pre-meds and med students, and there's an overwhelming number of students right now applying to medical school. I mean, it's competitive.
I mean, do we blame them though? Like, do we blame the new age physician at all?
Okay,
they're playing the game that is, okay, I could either go this direction and be miserable, and you talk about physician suicide, right? You talk about physician suicide's a real thing. That's insane. That is insane. What used to be the most, I remember when I was young, and one time my dad went and paid the bill for someone. I didn't know who it was at this time. He's like, oh, that's our family physician. Paid the bill. I'm like, well, why'd you do that? I just didn't know. I was young. Well, why'd you do that? That's what it used to be like. Now you get the young, smart people who are coming into this trying to make money and not be burnt out. Like that's the choice that I would make. That only makes sense. And it's all being pushed down from top to bottom by the almighty dollar. That's what it comes down to.
Oh, it is, absolutely. And I think the younger generation does seek and value work-life balance. I just did a keynote speech down in South Carolina for some of the nurse anesthetists, and I said, the millennials are getting picked on. I said, but you have to realize the boomers and Gen X, we're working ourselves to death. And at the end of the day, I even told them, I said, you know what? You know who's not going to be at your funeral? I can tell you this. The CEO of your organization won't be there, and a majority of your workmates won't be there, but your family and friends will be. And no one's going to say, gee, I wish they spent another day in the operating room or the office seeing patients. So, unless that really floats your boat, and again, the work-life balance, for some people, it may be a 50-hour work week. For some, it might be a 30-hour work week, but they want flexibility. They really want that agency, and they also want to have a voice, make a difference. So I'm optimistic really about those who are sticking it out.
Okay.
And I'm working alongside these kids, and they're super fun. They're excited. They're smart. They get it. And they're listening to what I have to say, like a sponge taking up water, because I'm one of the older generation now who kind of gets it. And I just don't candy coat it, so.
Thank you.
I do not candy coat anything. I tell them it's a jungle.
I really appreciate that because I think they need to hear this, because I think as they go through medical school, they don't hear it, and they're kind of just taught, do your thing, keep your head down, take care of patients, and then they get out and they're like, wait a second, this is not the picture that I was painted. And that leads to the burnout too, because they aren't informed early. If they can be informed early and then they can decide what they want to do that makes them happy, they'll have a happier trajectory of their career, I think.
Yeah, absolutely. I think that's just it. I tell them, once you get done with the learning the nuts and bolts of medicine and you get comfortable with the clinical work, I said the things that are going to impact you are, first of all, your schedule and your workload. And then, whether or not you have that agency autonomy and whether or not you're being compensated fairly with the rest of your peers. That's it. At the end of the day, if any of those things are kind of out of balance, you're going to be seeking other employment, or you're going to be ripe to be plucked from wherever you're at. And that's the other thing too, that's impacting these students and residents, especially the new residents getting new jobs. I tell them the days of joining a practice and staying for 20, 30 years are done. Just get that out of your head. You're probably going to be in your new job for maybe 3 to 5 years. You may be there less if they haven't told you the truth. Have an exit strategy as soon as you start, and hire an attorney to look at your contracts and make sure you have out clauses that aren't going to burn you economically or professionally. And again, I have to say this, you have to really start acting more selfishly than you ever used to in the past. So
that's where DocNation tries to come in and help those physicians out there, is to look at all that before you sign on the dotted line, because there is a lot of people that end up having to move their whole family because they didn't read a part of their contract.
Right. No, absolutely. And I've been encouraging a lot of the residents now to kind of stay in academia for a while and continue to get more experience amongst a peer group that's supportive. And, academic medicine is just, I had a feeling I was always going to circle back to it. I didn't know when exactly, because I love to teach. I like the environment. It's kind of ripe for a whole lot of interesting things, not just providing patient care, but there are some real advantages. I always tell people too, in academia, you can hide a little bit, if you will, from I am somewhat insulated, not completely, but I feel somewhat insulated from a lot of the factors and economic impacts outside of these systems. So
sure,
that's one of the things. When you get to your stage in life, you have the most experience, you have more knowledge. Most likely, people are in better financial position than they were when they were younger.
Yep.
They're more socially connected. They know more people. You have so much more to offer. Your value is through the roof at this stage. And so for you to be there, to circle back and be a mentor and help that next generation. I heard through all the things you were saying about the doctor's voice has been lost. And that's the big thing at DocNation, is we want to do everything that we can to empower that voice to come back. And so whether it's the board of directors or like Dr. Nickel, a few podcasts back, he's like, doctors can't own hospitals anymore. Like, what you said, Anthony, the leadership or the stakeholders here don't align with the doctors, because doctors are not the stakeholders anymore. When in reality, as Reid was saying, they're the star player on the field. Like, there's no game. There's nothing to show up to watch. If
they're the only one that truly knows how to go from home base to home base.
Right.
Only one, like literally, the people calling the shots do not know how to round the bases. Now they might be very, very good. We got to have business people helping run a business. We have to.
Absolutely.
Not at the rate of 95%. I want to say one thing real quick. There's a young doc that just moved into my neighborhood, and he heard about me through the grapevine and what I've done for a very long time is built a career supporting physicians. And he said, I just got to say something. I've been listening to a few of your podcasts, and I feel like you're like calling us out like we wouldn't strike. And he's like, I got to tell you this right now. I'm not going to be doing what I'm doing today for 30 years. And I know a whole lot of other people who feel the same way, and we would be okay doing that. Obviously, I'm not going to put his name out there right now. One day I want to have him on the podcast, but I do see something with working for physicians over the last 15 years. The older generation, they don't even like sometimes to have the conversation about striking. The younger generation is looking at the next 30 years of their life, seeing some of their peers commit suicide, or at a minimum be extremely depressed for a very, very long time, saying, I'm just not going to do this for 30 years. What's another option? And here's an option. And so that was a really enlightening conversation and encouraging. And what brought that up is, Matthew, you're spending so much time giving back to the next generation. If there's anything we can do, maybe host a monthly meeting with that group to help them with individual representation. I love that you said, hey, we got to start getting a little more selfish. And it's sad that we even have to talk that way, but
it's true.
DocNation exists to do just like a professional athlete has an agent. That's what we exist to do. And to get every individual doctor to have real representation, real knowledge. There should be no question marks. Realistically, there should be no research. Come to us, let us educate you. And that's one pillar. And the other pillar is obviously the conversation I had with that young doc. I mean, he was fired up. He's like, I love what you guys are doing, but don't get it twisted. There's a new generation who isn't going to be doing this for the next 30 years. And so tell me where to sign on the dotted line. I'm like,
well, and see, and I think that's
the podcast.
That's just it, you know. And I think too, the other thing, and we didn't really touch on this, but the DEI efforts and the blowback, well, that's going to come boomeranging back with the younger generation. They're not going to tolerate a lack of DEI and addressing some of the social determinants of health and everything else. You know, there's a segment still of the younger generation, and I've told them, I said, I get this from you guys. You are in a way social justice warriors too. You are seeking equity, access, and you're wanting to view the healthcare system ideologically in that way. Unfortunately, boomers are retiring, so that segment of the physician population definitely won't do it. I'm Gen X. We're kind of the oddball feral children that were latchkey kids running around the neighborhood until the lights went out, or the lights came on, sorry. And so we're just in a different category as well. And we were taught by the boomers, so we have more in common with them, both work ethic wise, et cetera, than we do with the younger generation. But I'm really, really looking at the new Gen Zs and the Ys and the millennials as they come up, because each generation has something unique to offer, and they've been through something unique. And I just don't find the generational bashing to be helpful, even from a burnout perspective either. You know, this calling them lazy because they don't want to work hard. How is that helpful? You know, I mean,
well, they're getting paid a heck of a lot less than people who've been in practice for 30, 45 years.
Well, they're
looking at straightforward factual numbers and saying, listen, this is so abusive. I don't care what anyone thinks of us. We're willing to fight. And so I'm just encouraged by that. You know, the truth is DocNation shouldn't even exist. This company is successful, and it shouldn't be. There shouldn't be even a reason to have this company in terms of at least the second pillar of creating a union. Like, medical professionals shouldn't have to break an oath, basically, to strike, to give up their moral value, if you will, just to get treated right. You know?
Correct.
And so the guy I was talking to yesterday said the smartest guy in residency is in a hospital right now and has been for 30 days. And he never talked about suicide once, but he can't eat. He's hooked up to a feeding tube because he's so broken. He's so broken because he's so stressed out. And it's like Anthony says all the time, you don't hear of a doctor quitting medicine and excited to step up to something else. You don't.
Right.
It is the creme de la creme profession, and it's always going to be a step down, whether the money is a step up or not.
Right. Back to what you're saying, though, are physicians now professionals or employees? If you look at the other, you know, top box profession, if you will, engineering, but more importantly, I look at law and I look at attorneys. First of all, are attorneys talking about unionizing? Absolutely not. Are attorneys owned by private equity? No, they are not. Are attorneys being told how to practice law? No, they are not. Okay, so they are true professionals in the sense of the word, and they've preserved it. But when physicians become employed and then they're punished for not following protocols, or they're punished for speaking out, what are we now? Are we professionals, or are we just an employee that needs to toe the company line?
We're a cog in the machine,
You know, that's part of what's exacerbating burnout. We want to be treated as professionals. And, you know, Congress and states attorney generals view us as professionals. Are we entitled to overtime? No. But if you ask an attorney, hey, you have a phone call every 15 minutes, that clock's running, or every minute the clock runs.
Yep.
You know, they're a very expensive taxi cab.
Just an email that they send you.
Yeah, of course. You know,
an email from an attorney costs you $100.
Exactly. That's, you know.
I tell them not to respond. I go, don't respond. Just read it. Don't respond.
Right. Yeah, exactly. No, so the thing is, I mean, the playbook, it's not that we can take the playbook from attorneys, but when we were independent and we did own ourselves. We did have that same professional image.
Yeah.
And I think too, when you're a business owner, when I was in Tucson, for example, as a shareholder partner for my own group, it was our business, and it was our business to take care of our business. And of course, our business was the patient, but our business too was the surgeon. Our business was taking care of the hospital, and it was mutual. And we shook our hands and we got the job done. But if we're going to be brought into the fold as employees and then not treated as professionals, forget about it. That's where unions are going to end up becoming a reality.
That's right.
And I have discussed this.
One thing I want to end with is when you had that business, healthcare was better than it is now.
Yes, it was.
The patients had better care 15, 20 years ago than they do now. And everyone in America can agree on that. And that's why I keep saying DocNation or anyone needs to come together. The physicians need to come together, no longer just for the physician, but for the patient, because healthcare is dying because of the system that physicians are getting put into. That's where I'll end it, but it's the truth.
I agree.
Thanks, Matt.
Thank you very much.
Great to meet you.
Absolutely.
Thanks, Matt.
Yeah, you
Really
bet.
appreciate
your time.
Thank you.
All right. Thanks for inviting me. I really appreciate it. Have a great weekend.
We appreciate you. Thanks for giving back.
You bet. All right.
Bye-bye.
Bye-bye.
This has been the DocNation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.